Hi, I'm Dr. Charlie. I'm a lead GP and a senior university clinical educator. In this video, we are going to discuss HRT. We will explore the risk and benefit, how we should start a woman on HRT, the regimen, the preparation, how we can manage problems and issues associated once a woman has been started on HRT. Coming right up. Hormone replacement therapy, or HRT, is the most effective treatment for women experiencing menopausal symptoms. Benefits of HRT include reduction in menopausal symptoms such as hot flushes, mood swing, brain fog, aches and pain, improvement in vaginal dryness, sexual dysfunction, reduction in urine frequency and urine infections, increased bone mineral density, reducing osteoporosis risk, reduction in cardiovascular risk, and reduction in bowel cancer. There are also some risks relating to HRT to be aware. Oral HRT increases venous thromboembolic risk. Bear in mind that other risk factors are also contributing, such as increasing age, smoking, and obesity. Women under the age of 60, the absolute risk is low. There is a small increased risk of stroke in oral HRT. Bear in mind that in the baseline population of women under the age of 60, the risk of stroke is low, so the increased risk is thought to be non-significant. There is no evidence of increased risk of stroke in women taking transdermal HRT. The risk of HRT associated with breast cancer is contentious. It is thought to be equivalent to the risk associated with a woman drinking 2 to 3 alcohol daily or being obese. Currently, there is no evidence of increased breast cancer risk of using HRT under the age of 51, comparing to a menstruating women of the same age. There is an increased risk of endometrial cancer with using HRT. Being on a cyclical HRT initially, then switching to a continuous HRT at 1 year would remove this risk. All types of HRT contain estrogen, which ovaries no longer make after menopause. Estrogen leads to a build-up of endometrium, increasing the risk of endometrial hyperplasia and cancer. So it is usually combined with progesterone, which remove the risk completely. Both hormones can be taken in the same preparation, such as tablet or patch or separately. Women who had hysterectomy or has Mirena coil do not need to have a progesterone component of HRT. Some women with only vaginal symptom will only need a topical treatment coming in a cream, tablet or ring, and there is no need for a progesterone component here as the vaginal absorption of estrogen is very small. HRT come in different preparation, and some women may prefer a transdermal, patch, gel or spray to an oral tablet. There is no maximal duration for a woman to be on HRT, although it is useful to be discussing the risk and benefit at a yearly review. Transdermal HRT is associated with fewer risk comparing to oral HRT. It is more advantageous in women with BMI over 30, history of migraine, history of venous thromboembolism, diabetes, thyroid disorder, and gallbladder problems. It has less effects on clotting factors. It also reduces triglycerides. Women should be given sequential combined HRT if they have period in the past year, This is where estrogen is given daily and progesterone is given 10 to 14 days in the 28-day cycle. Period will happen every 28 days, equivalent to a light period. Progesterone causes a build-up of the endometrium, and the period will occur when the progesterone stops. Continuous combined HRT should be given to women who has been on sequential HRT for at least 1 year. It is also for those patients who their last period is more than 1 year, or in those patients with premature menopause with last period of more than 2 years. Transdermal preparation can be started at lower dose, such as 25 microgram and review at 4 weeks and increase to 50 microgram and so on. Younger women, such as those who have hysterectomy, may require a higher dose, which can be 4 times. Useful comparative doses are 1 milligram oral estradiol is equivalent to 25 microgram patch and 0.5 gram Sandrina gel. There are some side effects related to HRT use. Estrogenic side effects may include breast tenderness, headache, nausea, leg cramp, and bloating. Progesterone side effects may include weight gain, fluid retention, back pain, low abdominal pain, and acne. Examples of commonly used HRT in the UK are Transdermal, Everol, Sequi, which is a sequential combined HRT patch, and Everol Conti, which is a continuous combined HRT patch. Standalone estrogen preparation are Everol patch, estradiol, estrogel such as Sandrina, which can be given with a progesterone component such as utrogestan, given at 200 mg at night for 14 days of the 28-day cycle for sequential combined regimen, and at 100 mg daily for a continuous combined regimen. Example of oral HRT are Elest Duet for a sequential HRT and Elest Duet Conti for a continuous combined HRT. Women vary in their tolerance to progestogens, and the change in progestogen may be needed if not tolerated. Combined HRT contain norepinephrine and levonorgestrel. Medroxyprogesterone, dydrogesterone, and drospirenone are better tolerated as they are less androgenic, such as Angelique. Angelique has estradiol and drospirenone, which is an aldosterone antagonist, which is also useful in fluid retention. Let's talk a little bit about bleeding issue with HRT. The whole point of progesterone component in HRT in sequential regimen is to produce a predictable regular bleed. Utrogestan 200 mg is often given 2 weeks on and 2 weeks off, as it is easier to remember, although generally speaking in sequential regimen progesterone is given for 12 days. Medroxyprogesterone or Provera can be used as alternative to utrogestan as 10 to 20 mg cyclically. The duration of progesterone can also be increased to 21 days in sequential combined if the bleeding is heavy or irregular. Some women who experience side effects of oral progesterone can be considered for vaginal administration at the same dose. This is off license. Some women who has Mirena coil as progesterone component, this can be used up to 5 years of license. Erratic bleeding is common in the first 6 months of HRT. If the persistent vaginal bleeding is more than 6 months, further investigation is recommended. There is a 3-monthly cyclical regimen where estrogen is given daily and progesterone is given for 14 days every 13 weeks. This is useful for women with irregular bleeding as an option. It is also useful in those women who are intolerant to progesterone, where the bleeding occurs every 3 months. Thank you for watching this video, and why don't you check out another video I made earlier on menopause. Don't forget to like and subscribe to my GP Team Academy channel, and until next time.